Today, let's talk about DKA, diabetic ketoacidosis, and HHS, the hyperosmolar hyperglycemic state. These two conditions often confuse students because they appear similar, so many learners ended up memorization isolated facts. But memorization alone doesn't help in their clinical practice. So today, I will explain the core mechanisms using a simple schematic, the same one I teach my trainees. Alright, imagine this is a blood vessel, and here are the cells. Glucose in the bloodstream enters the cells with help insulin. Once inside, the cell make ATP and function normally. That's our starting point. In DKA, especially in type 1 diabetes, insulin production drops to almost zero. So glucose cannot enter the cells. Despite high blood glucose, the cells are starving. To survive, the body shifts to fat breakdown to make ATP. During this process, the liver produces ketone bodies, especially beta-hydroxybutyrate, the major ketone in DKA. Ketones are acidic. As they accumulate, the anion gap increases, leading to high anion gap metabolic acidosis. One of the ketones, acetate, spontaneously converts into acetone, which is volatile, meaning it evaporates and escapes in the breath. That's why DKA patients often have that fruity, acetone-like smell. High glucose pulls water out of the cell. That's osmotic shift. And in the kidneys, excessive glucose spills into urine, dragging water with it. This causes polyuria and worsen dehydration. On top of that, acidosis triggers vomiting, and Kussmaul respirations cause additional water loss through rapid deep breathing. So dehydration in DKA comes from several mechanisms working together, not just osmotic diuresis. The treatment directly follows the physiology. First, fluids. They restore perfusion and help stop ketone production. And second, insulin finally allows glucose to enter the cell again, shutting down ketone production. Third, potassium. How insulin works, potassium shifts into the cell, lowering serum level. So we always monitor potassium and keep it above 3.3 mg per liter to avoid dangerous arrhythmias. This is the essential treatment framework for DKA. Now let's compare with HHS. Students often struggle to differentiate DKA from HHS, but the underlying mechanism is very different. In HHS, usually in older type 2 diabetics, the body still has some insulin, and the small amount of insulin is enough to suppress ketone production. So there's no significant acidosis or only mild acidosis. But the insulin is not enough to control glucose. So blood glucose rises dramatically, often 1600, 1800, or even 1000. This extreme hyperglycemia causes profound osmotic diuresis, leading to severe dehydration, typically worse than in DKA. HHS develops slowly over several days, and patients often present with neurological symptoms due to high osmolarity. Let's summarize the essential contrasts. In DKA, almost no insulin, and ketone production causes acidosis. Glucose typically around 250 to 500. Acetone smell and abdominal pain and vomiting are caused by acidosis. Onset within hours. More common type 1 diabetes. HHS, some insulin present, no ketone, no acidosis. Glucose often over 600 to 1000. Severe dehydration and altered mental status. Onset over days, more common in type 2 diabetes. And remember, in their practice, overlap is common. Many patients show features of both, and in those cases, we treat the acidosis first, like DKA. Keep this simple schematic in your mind whenever you evaluate a hyperglycemic crisis. Once you understand the mechanism, the management becomes clear. Stay calm and act first. See you on the next lesson.